Hello, and welcome to the Center for Health Design's EBD Journal Club. Thank you so much for joining us today. I'm Katie Pedito. I'm your host for today's session. I'm an environmental psychologist and the architecture research lead at HDR. Before we begin today, I'd like to take care of some housekeeping details. Awesome. First, we'd like to thank the Health Environments Research and Design Journal for providing free access to the articles we review. If you have not already done so, we recommend subscribing to HERD. There is a discount code for attendees to receive 20% off the subscription using code HERD20. We do have EDAC and AIA CEUs available. The AIA verification form, the EDAC verification form, and a request for a certificate will be available in the chat window. In order to earn credit, you will need to complete the appropriate forms. To earn EDAC credit, retain the verification form for your records and self-submit the credit to Scantron at the time of your EDAC renewal. For AIA credit, please fill out the verification form and purchase a CEU management fee for $12 in the Center for Health Design store, and then email to Catherine Anchetta. Her email is listed on the form. To receive a certificate of completion, fill out the request form via a WooFoo link located in the chat window and purchase a CEU management fee for $12 in the center store. So all of the information you need is going to be in the chat box. The purpose of the EBD Journal Club is to engage the health design community in dialogue regarding important research to help us better understand the links between the built environment and health-related outcomes, and then apply it in the real world. We want this to be a conversation, and we encourage you to ask questions. The EBD Journal Clubs are formatted for a 15-minute presentation followed by a discussion. When you have a question, simply type it into the Q&A window. Access to the Q&A window is at the bottom of your screen. But if you are on a mobile device, if you're on your phone, it might be at the top of your screen. So before we get started, make sure you know where that Q&A box is so you can load up some questions for Michael. Speaking of, now I would like to introduce you to the authors of the article we're discussing today, Dr. Michael Madsen. Michael is an assistant professor at Arizona State University, where he teaches courses in technical communication and user experience. His scholarship focuses on wayfinding in hospitals, the training of healthcare workers, and drug safety, especially opioids and cannabis. Michael is also an adjunct associate professor at the Medical University of South Carolina. Thank you so much, Michael, for joining us today.
Thank you for that introduction, Katie. And thank you for the invitation to visit the Journal Club here today. At the outset, I would like to acknowledge my wonderful collaborator and co-author, Kelsey Goodwin, who unfortunately could not attend this session today. Our study, Color Coding the Labyrinth, took place at a resource-constrained Level 1 trauma center located in the southeastern United States. And there, wayfinding was noted as a challenge year after year. Oops. There we go. So our objective was to pilot a two-part wayfinding intervention, which you can see here on the screen. The first part was to establish colored routes to major sections of the emergency department, which the staff call pods. There is an A pod, a B pod, and a C pod, and thus a yellow route, an orange route, and a green route. The second part was to implement corresponding visitor badges. Here's how the two parts work together. Imagine that a visitor checks in at the front desk. They ask to go to room number 3, which is located in A pod. The desk nurse writes the number 3 on a yellow badge, gives it to the visitor, and tells them to follow the yellow line on the wall. Because of the color coding, staff can hopefully tell quickly if the visitor is wandering or lost. Admittedly, this simple, low-cost intervention was not intended to be a cure-all to the emergency department's many wayfinding woes. Although the facility may look neat and tidy on the floor plan, as floor plans tend to do, Visitors and others would still need to deal with multiple numbering systems on the doors, a lack of signage at decision points, clutter on the walls, staff moving from place to place, beds and monitors placed in the hallways, and a long walk over to C-Pod, which was not originally part of the emergency department. We knew that not all of these problems were solvable, especially on a shoestring budget, but we thought that our intervention could simplify some of the on-the-ground complexities of wayfinding, and we did a variety of assessments that considered visitor and staff experiences. But because it was the most systematic, we only included surveys of staff perceptions in the article. Here's how we got started. In an internal survey, we quantified staff satisfaction with wayfinding and found some very high numbers, and not in a good way. About 95% of survey respondents were dissatisfied or very dissatisfied with the wayfinding of non-emergency department staff, meaning that doctors coming for consults, for example, were getting lost too. And 97% were dissatisfied or very dissatisfied with the wayfinding of patients and visitors. Typically, they needed to be escorted to their destinations or given long-winded and rather complicated directions. We're not exactly sure about the response rate in any of our staff surveys, since the hospital considers precise staffing numbers to be confidential. But we were told that most years, the emergency department employs about 50 physicians and about 100 nurses, technicians, and secretaries. For convenience, we refer to all of these groups as staff. To supplement the pre-intervention statistics, we collected pre-intervention comments, which I will show you in a minute. There we go. Here are some of the things that staff shared. We were working a gunshot victim and 3 family members walked in the door thinking it was C-Pod. I found a lady wandering on the B-Pod when her visitor pass said C-Pod. I discovered that she couldn't follow the direction she was given because she didn't know her right from her left, at least in that moment, and perhaps while she was under duress. Finding lost and scared family members breaks my heart and clearly increases their stress. This combination of quantitative and qualitative data helped us communicate about the wayfinding problems with some precision. And we were fortunate to receive support, verbally at least, from the Shared Governance Committee, nurse managers, the head of quality improvement, the head of emergency medicine, and C-suite executives, such as the administrator over the hospital's clinical service line and the patient experience head. Since there is no gold standard for assessing wayfinding, we developed 4 quality criteria based on the Donabedian model of healthcare quality. The Donabedian model can be summarized like this. Structure directly influences process, and process directly influences outcomes. In terms of structure, we wondered how visible the colored routes and badges were. We discussed the possibility of placing the routes in a variety of places, on the floor, on the ceiling, at eye level. They ended up in none of those places. They ended up being placed at thigh level or waist level, because that's where there was space and that's where they were perhaps easiest to install. We also wondered about the size of the visitor badges, which we could easily alter if needed. Subsequently, we set visibility as a quality criterion. In terms of process, we wondered whether the staff would readily use the routes and badges in their day-to-day work. And this is what we meant by the quality criterion usability. We also wondered whether the routes and badges enabled staff, according to their own perceptions, to give directions more quickly. So we set efficiency as a quality criterion. In terms of outcomes, we were most concerned over staff perceptions of effectiveness overall. So to triangulate, we defined effectiveness in a positive way and in a negative way, so to speak. The negative way was essentially the intervention led to fewer people getting lost. And the positive way was more ambitious. It was wayfinding is now easy in the emergency department. We use these 4 quality criteria, visibility, usability, efficiency, and overall effectiveness to derive statements that staff could rate on 5-point Likert scales. We distributed these surveys electronically about a month after training the staff and rolling out the intervention. We sent out weekly reminders through early April 2019. And here is what we found. The colored routes and badges were visible. Nearly 80% of the respondents agreed or strongly agreed that the colored lines on the wall and the badges were easy to see. The colored routes and badges were usable, but not equally so. Nearly 80% of the respondents agreed or strongly agreed that I typically point out the colored lines on the wall when I direct people to their destinations. In contrast, only about half of respondents indicated the same about the visitor badges. The colored routes and badges were efficient, but again, not equally so. About 80% of respondents agreed or strongly agreed that the colored lines on the wall allow me to direct people to their destinations faster. The visitor badges, about 62% of the respondents. Still, the colored routes and badges were effective overall, according to staff perceptions. As in the previous two quality criteria, usability and efficiency, the colored routes were perceived more favorably than the badges, but the badges were still perceived favorably by the majority of respondents. However, particularly important to us, about a third disagreed or strongly disagreed that patients and visitors can easily find their way around the ED, and nearly 2/5 disagreed or strongly disagreed that staff who do not work in the ED can easily find their way around the ED. For us, this was a clear indication that there was more work to be done. Our findings are, of course, specific to this emergency department and should be generalized with caution. Still, to conclude, let me suggest some possible takeaways. There we go. Simple interventions involving color coding may help emergency departments, including those under tight resource constraints, address wayfinding challenges. Of course, we need to be cognizant of possible challenges with color blindness or other sorts of visibility impairments. Staff perspectives are valuable in the design and assessment of wayfinding interventions. In fact, they may be easier to collect and analyze systematically than patient and visitor perspectives. The Donabedian model can usefully inform assessments of wayfinding. And at least in our study, wayfinding quality can be understood as visibility, usability, efficiency, and overall effectiveness, but additional research is needed in this area. For example, can we extract additional wayfinding quality criteria from the Donabedian model? And what is the statistical relationship between them? For example, if a participant perceives a wayfinding intervention to be highly visible, how likely are they to perceive the intervention to be highly effective, and so forth? Finally, emergency departments should work to improve not only their productivity, but also their accessibility and user experience. Wayfinding particularly, and good design generally, is a critical component of all three. Thank you very much for listening. I am happy to address your questions.
Wonderful. Thank you so much, Michael. Now it is your turn to ask questions of the author. So please feel free to type any of your questions that you may have in the Q&A box, and we'll do our best to answer them. Again, please type them in the Q&A located at the bottom of your screen rather than the chat box. So the Q&A box at the bottom of your screen. If you're on your phone, it might be at the top. We already have some questions coming in, which is fantastic. Wonderful. It looks like we have a couple of questions about maybe how we developed this intervention and how these colors were selected. So let's start from the beginning. Sarah has a question for you. Can you speak a little bit more about the development process for this intervention? How did you end up with the badges and the wall lines?
It was a long developmental process. And we basically looked at other hospitals to see how they addressed wayfinding challenges. And we were especially inspired by two different sources. One was the hospital where Kelsey, who was a registered nurse, worked previously, who had divided the emergency department and other facilities into pods. And we were also inspired by children's hospitals that seemed to do a really good job at getting people from place to place and taking some of the administrative edge off of the process of moving from place to place. And initially, we were thinking of doing something more complicated, like we had seen other hospitals do. For example, having kind of a bus route system or a subway system, so we could say, your room is right next to red line, stop number 3. But that seemed to add an additional layer of complexity. And so over a process of talking with the shared governance committee, especially a group of nurses who participate in the administration of the emergency department, we decided that simple was the way to go. And we found a company located in Colorado that makes floor tape for hospitals. And we decided the colors based on considerations of color blindness, as Kelsey's father is actually colorblind. So this is something she is very sensitive to. And he actually walked through the emergency department to give us some initial data. And we considered the colors that the supplier already offered, trying to maximize the contrast. Yellow and orange is a little bit iffy, but they do provide some nice contrast with the green. And so where did the project come from? By stealing stuff from other hospitals and talking a lot to various stakeholders at our local context.
And Casey wants to know, what were the stripes? Were they tape or paint? And were there any infection control issues? Were there any aesthetic concerns? Did you have trouble maybe integrating it with the existing branding of the facility?
Yes. In fact, I think the facility ended up taking the lines down, not because they didn't work, but because someone from branding walked through and said, hey, our hospital is blue. Everything needs to be blue. But they were tape on the walls. And if nothing else, we did show that color coding works. But apparently one of the stakeholders that we did not adequately engage were people from branding who had very strong opinions about a year after the lines and the visitor badges went up.
And why do you think, while we're talking about these lines, why do you think the lines on the wall outperformed the visitor badges? That was part of your results section.
Yeah, I think one reason why they outperformed the visitor badges was because they were more utilitarian. They went through most sections of the emergency department, whereas the visitor badges were placed at the front desk, and they assume wayfinding experiences that essentially start and end at the front desk. The staff wouldn't use the visitor badges, for instance, for ambulance staff who are coming through the back door, or someone who came in through a side door, for instance, from the hospital cafeteria and started to wander. And so I think that the routes ultimately outperformed the visitor badges because they had a broader indication of uses. In the qualitative comments to the survey, staff also suggested that perhaps some follow-up trainings on the badges at the front desk would have been helpful, or maybe some signage to remind them, especially during busy hours, that they're there and they'll help save time if they're used.
That was part of Jennifer's question. She asked, did staff find giving the visitor tags to be an increased workload? And what did you actually use to attach the visitor tags?
These were stickers that were printed out by the hospital's printing office. And you could see the scale on the previous slide with the US quarter for scale. And so they were printed out on paper with a sticky backside. And based on our usability metric, it seems that staff were generally willing to use them. In addition, we had nurse managers help us audit for compliance. Kelsey went down there from time to time and did ethnographic observations. I sat down there from time to time for ethnographic observations. And we found, at least when we were there, maybe because we were the face of the project, the wayfinding visitor badges were generally used even during peak times, though I certainly don't blame the staff if during busy hours they decided to streamline the process a bit and not use them.
And just to clarify a little bit about the relationship between staff and patients when using this wayfinding strategy, an individual from Cajun Architecture asks, was the goal of the routes to lead patients to the care team station? How did patients find their route to areas where there might not be staff to guide them?
Well, we basically wanted to simplify the complexity. And so the routes alone wouldn't necessarily take people to the precise room where they needed to go. And so usually staff would use a combination of directions, like saying, follow the green line to C pod and then look for your door on the right, or bed number 3 is on A side. So go through these doors, find the yellow line and follow it around the corner until you see door number 3. And so the routes would basically go through the major places where patients and visitors needed to be. And if we couldn't get them to the exact destination, we could at least get them in the right direction and pretty close.
And Michael, your background is in, I know, in technical communication and also in user experience, and not just in hospitals and not just in the built environment. So in UX, often we talk about this idea of redundant queuing, using more than one modality to inform individuals about the actions we might want them to take. So there's, in that line, there's a couple of questions here. Denise asks, how helpful would color-coded floor patterns be combined with the same color-coded wall feature? And maybe what about intentionally located artwork or any other strategies you think might help that redundant queuing here?
Oh, yes to all of the above. One of our initial ideas was to have more distinct landmarks or more distinctive artwork or photography in the emergency department, so staff could say something like, go down to the picture of the helicopter, take a left, and then go towards like the vase of flowers or whatever it would be. The problem was that this facility was very, very resource constrained. It's associated with a state government down south, and I'm told that only 3% of its operating budget actually comes from the state. The other 97% needs to come from additional sources. And so that's why I tried to emphasize we were on a shoestring budget and we used tape because tape was cheap. But ultimately, if we had our wish list of things that we could do in an ideal situation, we definitely would have done something with the floors and with the paneling to do something more like, say, the Rochester Children's Hospital does, with more distinct themes to help cue people as to whether they're heading in the right direction and how do they know when they reach the right destination. So we went with the tape because it was cheap, but ultimately we would have loved to do something with the floors.
Awesome.
And with landmarks as well.
H. Rieger asks a similar question. Did you incorporate the colors that you chose for the badges and the routing into any other signage as well?
We would have loved to, but all of the signage was blue, and we were told that the hospital was way too poor to get new signage. We had started to look around for different grants, for instance, from AHRQ, to see if we could tie it into patient safety somehow. But I think that color-coded signage probably would have been just as effective, if not more effective, than the tape on the walls. And it probably wouldn't be as troublesome in terms of branding, especially if we could get branding on board early.
Yeah, and on that note, about cost and maybe return on investment, Mary had a question. She asked, do you have a sense of overall cost for this project between the striping, the painting, printing the badges, maybe training the staff versus what the return on investment might be? I know you don't have a full business case developed, but maybe for some of our folks who are interested in implementing something more lo-fi like this, what might you advise them?
Yeah, return on investment. We quantified it in terms of staff satisfaction with the intervention. And I have to plead ignorance here because my wonderful collaborator, Kelsey, was the business mind behind all of this. And I know that the tape was cheap enough to persuade a resource-constrained facility to buy it when they thought they couldn't afford anything else. So yeah, I mean, that's a good question. What is the return on investment in terms of dollars and cents? I'm not entirely sure. And actually in the wayfinding literature, I haven't seen, it seems like most studies go back to this study from, I think, the year 1990 that was done in Atlanta, if memory is serving right, where a researcher was actually to quantify wayfinding saves the facility this much money. And this is definitely an area where we need more studies because it's difficult to do, but those statistics are very, very persuasive if we can get them.
And I'm going to answer or ask a couple of questions at once because there are a number of folks who are talking about this idea of integrating with branding, integrating within the design process. Kristen specifically says, do you recommend being part of the design process to incorporate visual cues into the wayfinding? How do you think being incorporated earlier in the design process would have affected the outcomes
Incorporated
here?
earlier into the design process? Well, it would have saved a lot of headaches. This was an emergency department that does a lot of bootstrapping. It was originally designed to be a much smaller facility, but because the city around it was exploding, because it's a popular tourist destination, they had to incorporate other parts of the hospital, which is why it has such a funky shape on the floor plan. The hospital said, whoa, you guys are really busy. Here's a whole nother wing of the hospital that we're going to now call the emergency department, and patients had to walk down a fairly long hallway. But integrating wayfinding early in the design process is, I would say, is definitely a best practice, not only because it helps contribute to patient-centered care, but because it often enables more intensive interventions compared to putting tape on the walls, which are kind of band-aids on an open wound.
Sure. And
when a
you
suture
might
might
not
be
have
needed.
the answer to this, but Margie is curious if you know why maybe the ED staff or administrators not step in when branding objected. Do you have any sense of why maybe branding trumped some of the other opinions in this team?
I asked around and nobody would tell me. At this particular hospital, the branding people sit on the president's and the CEO's council. And so I think that some of the branding people even have more authority in the hospital than the patient experience officer and the head of the clinical service line. And just kind of my sense of the organizational culture was that some people had some trepidations and hesitation about branding. There seems to be some organizational history there that I wasn't privy to, but it's something that the hospital was very, very sensitive about. And one thing we should have done better was getting branding on our team when we were collaborating with these different stakeholders.
I think
Why
that
didn't they stick up for us? I'm not entirely sure. Maybe we didn't evangelize the results to as many people as we should have, or maybe there was someone outside of our stakeholder group who exerted influence from the outside. Not entirely sure.
I think that's something that a lot of folks watching this webinar relate to, that there are a lot of stakeholders, sometimes invisible stakeholders, that you might not realize are exerting an influence on your project. And I think that answers Morgan's question here, that facilities might be more likely to stick to a color-coded system if it's coordinated with branding ahead of time. So let's see, I want to get back to this idea of process here, but first I'm curious if you don't mind scrolling back to the photos of the routes and the badges. I think that was your first or second slide. One attendee was just asking if we could look at the photos again. And to all of you asking questions, I'm trying to ask questions in a thought order rather than the order that they're coming in. I promise you I will try to get to every single one of them. So while we're talking about this, Alex has a question. You mentioned Rochester Children's Hospital as one of your benchmarks or inspirations. Were there other children's hospitals you looked at for wayfinding examples?
I don't remember the names off the top of my head. One of the hospitals that I do remember being very influential, that I believe is a general hospital rather than a children's one, is the Shands Hospital, which I believe is associated with the University of Florida. And they do floor tiles that say things like, follow me to the X-ray room, or follow me to the eye room or the emergency department. And they actually cut those routes into the floor so that there's no possibility of being a tripping hazard. But there are so many good children's hospitals out there. And in a lot of ways, I think they're some of the gold standards for hospital wayfinding.
You mentioned tripping hazards. Any concerns about infection control? Did that come up during the course of the intervention?
Infection control, yes, it came up in a couple ways. We initially wanted to put the lines on the floor because we thought that's where they would be most visible, and that's where we seem to see the most precedent at other hospitals. And so we put down a piece of tape as kind of an experiment near one of the really busy parts of the emergency department, and just left it there for a few weeks to see what would happen. To my eyes, it seemed fine, but we had the head of facilities come down and take a closer look. And he thought that even though this tape was designed for hospital floors, he thought he could see signs of chipping already, and he felt really uncomfortable putting it on the floors. And the hospital was about to undergo a reaccreditation inspection from the Joint Commission. So he is feeling pretty leery anyway. He's like, okay, I love this idea, but please don't touch my walls and please don't touch my floors. Let's kick this to another time. And so, I mean, we tried to negotiate a little bit and say, well, what if the lines didn't go down the middle of the floor? What if they were at the sides of the floor, maybe on the toe kicks? But as you can see from the photos here, we ended up putting it at thigh level underneath the bumpers, because that's really the only space that was open, because the hospital has a lot of stuff on the wall. They have those bumpers, they have doors. So if we couldn't put it on the floor, we put it on really the only space that was available. And the visibility still turned out to be okay.
And that brings us to our first question that came in while you were talking, actually. And I wanted to address this, especially in the context of universal design. So I have a couple of questions in that line. But the first one is, this individual is interested in how you chose thigh level. What is the height of thigh level? And that differs, right, between men and women. So how did your team end up reaching a decision about the thigh height that you're going to utilize for the routes?
Because that's the only place where we really had space. And that's the only place where maintenance would agree to put it on the walls. It's my thigh level, but for someone else, it could be waist level. And if you look at the picture here on the left, you get a sense of what thigh level means. And so when I say thigh level, I don't mean that we intentionally wanted to put it at the thigh of every single person who came through. I'm really just saying we put it kind of low on the walls because that's where there was space. And to give you some sort of visual of how high these walls are, I'm 6'2". It comes up about to my thigh. To Kelsey, who's shorter, is probably closer to waist level.
And I can see in this image here that you were kind of space restricted with where these railings were. I think this is a great example of what maybe forced your hand in terms of making a decision about this height. Again, in terms of universal design, there are a lot of questions, and you briefly talked about the idea of color coding for individuals with color blindness or different visual impairments. Mardell Shepley indicates that people remember shapes more easily than color. And is it possible that maybe using shapes in lieu or, again, redundantly with color could be a strategy here? What are your thoughts on that, either in this intervention or in general?
Oh, absolutely. When I presented this intervention at a conference early on, someone said, have you ever seen like water pipelines? They do use shapes to help distinguish between pipeline A and pipeline B and pipeline C. And so maybe putting triangles on the orange line or circles on the green line or squares on the yellow line would definitely help with the redundancy. Or maybe even just simple lettering that says something like, green line, follow me to Seaside, or you're almost there, to give people a better sense of orientation. So yeah, if we could level up the intervention, I would definitely consider shapes to help accommodate those who are either under a lot of duress or people who have visual impairments of various kinds.
And Mohammed Asadollahai said, thank you for sharing your findings. And he's curious if there are any other wayfinding approaches or strategies that might seem innovative to you. We just talked about shapes, but is there anything else in your experience that you're really excited about?
That I'm really excited about? Man. That's a question I wasn't prepared for. I mean,
maybe anything about different sensory systems. Have you seen anyone using sound or haptic feedback? I don't know if I have, but I'm trying to think through maybe what these innovations might include.
I haven't seen sound, at least in emergency departments, because it tends to be such a busy place anyway. But I'm kind of intrigued by the idea of haptic interventions. In parks and green spaces, I've seen a lot of braille on railing, for instance, so that as people are following along with their hands, they can feel the direction that they need to go to, or they can feel the room numbers as they're going along. It looks like a lot of the innovation in wayfinding is starting to focus more on digital apps. And we briefly discussed, well, like our emergency department isn't huge, but would it be possible to provide some sort of cell phone app that could talk people to the different locations or provide a more detailed map on the website? I was just thinking back to children's hospitals. I don't know if this would be appropriate necessarily for an emergency department, but I think it's cool when the different sections have a really distinct theme, some of which are reflective of the local surroundings. So maybe A side is the beach themed section where there's oceans and waves on the walls, and maybe there's a blue line leading to it. I think having a deeper theme in the building can do a lot for wayfinding. It helps people know if they're heading in the right direction, and also if they're there. If they know they're looking for beaches and waves and bridges when they're near their room, then it's much easier to find than just, say, an orange line on the wall.
Yeah, I appreciate you theorizing out loud with us. I think that supports Marianne's question here. She asked, do pictures help even more than shapes or colors with wayfinding?
That's certainly one theory. When we looked into the literature, we found that there's basically two major schools of thought with wayfinding. And one is the root system. So basically people know, I go down this hallway 10 steps, I turn left, and then my room is right there on the right-hand side. And the other major school of thought in wayfinding is landmark-based. So people know, I turn right, I find a picture of the helicopter, and my room is right outside there. So a combination of those two can be really useful. And we did use a little bit of landmark wayfinding when we were directing people on the green line, because the patients and visitors have to walk down a hallway that sometimes isn't very populated. And when we tested the lines in real time, having people think out loud and basically sending them on a scavenger hunt, they would often turn down this hallway and say, whoa, where did all the people go? Where's all the beeping monitors and stuff? Am I in the right place? Am I allowed to be here? But if they know, okay, if I see the picture of the helicopter over the ocean, then I'm in the right spot. So landmarks could be very, very useful in that regard.
And let's see, Patricia asked, how did you address locations at a cross point, which I think is illustrated in this photo that you have here? So not yellow, not green, but in between. Did you have to rely on another visual cue or something like landmarks?
At a cross point, I don't know if I'm super familiar with that particular term. I use the term decision points in my presentation, and I meant something like this, where people had to make a choice to turn to the left or turn to the right. But the colored routes would take people to all of the major sections of the emergency department, except for DPOD, which was the psychiatric ward. And because of the sensitivity of the care there, we were advised not to take people there on the routes. Those people visiting that section would just need to be escorted. But like I mentioned with CPOD, because there could be a long hallway without a lot of other visual cues, the staff could say things like, look for this particular picture on the wall, and that'll help reassure you that you're in the right place and you're going in the right direction. But otherwise, I mean, you can see the walls, there's not a whole lot to describe unless you want to be really close to these like staff evaluations or these pictures of something. The walls are filled with clutter, but it's not a lot of distinct clutter that provided landmarks except for the hallway down to Seaside.
Right, it would be hard to say turn left at the bulletin board when there are a ton of indistinguishable bulletin boards. Sure. I am not checking the chat very often, but I do see a chat message here. And I'm interested in getting your thoughts on this, Michael. Grayson asks, do you think over time that maybe, let's look at the rails here, right? The rails are taking up a lot of space on this wall. Do you imagine a world where these rails might become digitized and illuminated as it senses people walking by? Do you think that maybe that's the direction that wayfinding is heading, this integration between technology and sensors and strategy?
Maybe. I think to have cooler bumpers with lights or sensors, there has to be a team of administrators who really, really cares. And in my limited experience, wayfinding is often an afterthought, where it tends to be focused primarily on signage. And I think there's also some cultural and stylistic preferences, even if bumpers that light up or sense motion work really, really well. Different administrators and different nursing teams might just have various preferences for how they like to direct people. They might say, well, the colored lines on the wall work, and the flashing lights on the bumpers bother me, or they're always going off. I have light fatigue. And so I think technology could certainly go in that direction, but it would need to be localized to particular administrative and care teams to really be effective.
Michael, you're providing some great takeaways for folks who are really hoping to integrate something like this in their projects in the future. So thank you for being so thorough and forthcoming about the process that you went through and some of the barriers and challenges that you've experienced. I want to get back to the staff experience quickly before moving into a little bit more of the research and methodology. Widya asked, how long did it take for the staff to familiarize themselves with the color coding? Did they catch on pretty quickly?
They did, as long as they were there for the initial training. By the time we surveyed them, they had been using the routes and the badges for 4 to 6 weeks, though in our survey data, we saw that there were some people who came on board after we did the training, and they said, oh, that's what the routes and badges were for. We thought, why didn't we do a second training? Or why didn't your coworkers help you out? So there were 1 or 2 people who weren't really familiar with the intervention, but once they learned about it in the survey, they said, oh, that's such a great idea. I'm going to use that from now on.
So in some ways, this survey almost became a training tool.
Sort of mechanism. It's also an
well, that's why in
for
college and higher education, right? We use tests to reinforce what we've learned. So in some ways, a survey can function that way.
Exactly.
Interesting. A follow-up to that, if a visitor got lost, how did they recover to the right path? Did your qualitative research reveal anything about that?
Yeah, after we put these interventions on the wall, we were curious, what do we need to do next? The hospital doesn't have a lot of money. So if we're going to push hard for an additional wayfinding intervention, what should it be? Should it be for signage at key decision points? Should it be for lettering or shapes on the lines or higher quality visitor badges? And so we recruited a group of 10 older adults, taught them how to think aloud, and basically sent them on scavenger hunts so that we could witness the process in real time. And just by following them around, recording their transcripts of what they were saying, we found that they would recover by asking people in a lot of ways. And not that they couldn't problem solve. The signs on the door seemed to be very important, but the staff in the emergency department were kind of already used to finding lost and wandering patients and visitors because it had been happening for so long. So of course, our goal was to reduce the number of times the staff needed to direct people. We found research that showed that the more nurses are interrupted in the delivery of patient care, the more likely they are to have medication errors or other sorts of things that can be harmful to patients. So it's not like patients and visitors were entirely on their own as they were navigating from point A to point B. And they did actively problem solve, especially with room numbers, but there were staff wandering around who would approach them and say, oh, you look lost. Can you help me find the place? Or, oh, this door is just right over there.
And so speaking of kind of the integration of staff and staff processes with this intervention, Emmanuel has a question. What is the relationship between this model and the typical building management system with access control doors or the use of access cards? How does this work together?
Fortunately, this emergency department does not have a lot of access points. Staff, patients, visitors need to have someone buzz them in to get beyond the initial doors, and you come to this decision point that you see here on the left. But after that, it's all open doors. And on this next slide, or maybe it was 2 slides down, there was a story shared of a family member accidentally wandering into the trauma bay, which also is not access controlled, maybe because staff need to get there quickly and an access point could certainly slow them down. But again, fortunately, there wasn't a very heavy duty access system in the emergency department once people got beyond the front doors.
And the first question that came in the course of this presentation, an anonymous attendee was asking, how this might lead to a gold standard for wayfinding, maybe one that might be universally applied to other types of spaces. And what I love about this question is that the attendee suggests that we probably have to do multiple studies at multiple sites longitudinally over time. So I want to use that as a jumping off point to talk about specifically your research here, now that we've talked about the intervention. Kaylin had a question. Early on in your research process, did you try any design research methods before applying the tape? Did you maybe assess users for preferred wayfinding colors? Did you get users to maybe test in a prototype, for example? I know you gave us a little bit of an idea about your development process, but was there any kind of pre-research going on there?
A little bit. I kind of came on the project in medias res. My collaborator, Kelsey, had been thinking about this problem for literally 2 years, but just couldn't get the internal support to do it. And she had started a lot of conversations with the shared governance committee in particular. And that's where we tested a lot of our design ideas. And so we would ask on some of our surveys to the whole staff and in our focus group discussions, like, hey, wayfinding is a problem. How would you feel about lines on the wall? Or how would you feel about more distinct landmarks? How would you feel about better signage? And just generated ideas like that. And then based on these discovery sessions, we could go back to the administrators and say, hey, based on our studies, this is what staff want. Will you fund it? And again, because of resource constraints, we really had to pare it down to just things that would be really cheap. But we did ask, like, how do you feel about just lines on the wall? How do you feel about colored visitor badges? And the outlook among our stakeholders is actually pretty bleak. And the general feeling that we sensed was, anything is worth a shot. This place can't possibly get worse. And I mean, the emergency department is a tough place to get around, but it wasn't that bad necessarily. But of course, with the conditions of lots of patient throughput, people being under duress, the staff being really busy. I mean, I certainly understand those sentiments. So yeah, we talked to people all along the way, continued to refine our ideas, sort of like the double diamond approach that the UK design center uses of thinking broad, thinking narrow, thinking broad, thinking narrow, until we come up with something that we can actually afford.
I appreciate that you're talking about the process in terms of an iterative approach, but also one that was very constrained by different stakeholders and within a budget. It's something that certainly a lot of us that work in practice have to experience with a larger client. Did you consider surveying, Eric asks, did you consider surveying staff outside of the ED or other patients or visitors coming through the hospital for the study?
We did consider it. We didn't do it because of speed. We had a hard time telling which doctors were coming down for the most common consults, for instance. And I think that was part of the wayfinding challenges of staff who work outside of the emergency department. Maybe an optometrist would only go down to the emergency department a few times a year, or a neurologist. These weren't doctors who necessarily came down a lot. Or sometimes a nurse would find someone wandering in the hallway saying, I need to get to the emergency department, so they would come down. So we would have liked to have surveyed a broader sampling of staff outside of the emergency department. It was just really hard to be focused about it and tell who those folks were. Maybe with additional interviews and additional ethnographic observations, we could have decided on key departments that worked a lot with the emergency department, but we didn't quite get to that point. Maybe it would have been interesting to bring in staff from other hospitals, just walk through and say, whoa, this is really good, or whoa, this is really bad, to bring in outside consultants to get additional perspectives on what's working well and what's not.
I think that lends itself really nicely to Molly Storrs' question. If you were to do the exact same experiment, same budget, same content for your intervention over again, what would you do differently? You just mentioned a handful of things. Are there any other things you would do differently?
Get branding on board early, because that also would have influenced the colors we chose. And that would have been an interesting discussion the more that I think about it. We tried to choose colors with really high contrast, and branding might have said, well, our hospital's colors are blue, the lines need to be blue and gray and white, which will look prettier, but is probably less usable. I think another thing that I would have done differently is to rely less on the hospital itself for funding. I don't know of a lot of wayfinding grants, but I would have dug deeper and worked a lot harder to find external funding so that we would have more freedom to do what we want and have more value that we could bring to our stakeholders and not have to worry quite as much about the administrative oversight.
Wonderful. And Katie Kirkpatrick asked this question earlier on. Do you think this study has applications for newly constructed EDs where the wayfinding strategies can be designed from scratch? I think we've started to really flesh out that question, but what do you think specifically a newly designed ED or the design team for that facility might consider?
Yeah, I think one of the takeaways from our study is color is really powerful. I mean, look at these lines on the wall. They're not even labeled. They're not even pretty, but staff were really happy with them. And we did patient surveys as well, but they were not very systematic. The feedback was really good. And when we sent the older adults on scavenger hunts, it worked really well. And so if facilities can design color-coded sorts of wayfinding systems from the early stages, that could potentially save staff a lot of headache. Now, there could be a downside because I imagine that if an entire wing of a hospital was yellow or an entire wing of a hospital is orange, it's going to be super irritating for the staff. And so color can be used strategically, but a little bit can go a long way.
I want to talk a little bit more about this intervention as we start to wrap up this conversation. One individual in the chat and then an individual from Cajun Architecture in the Q&A both brought up a similar concern. Anyone who's ever been in a hospital knows that there's equipment, carts, all sorts of things that might be in a hallway that could potentially obstruct these stripes. Mm-hmm. How did you account for that? Was that a concern of yours?
Yes, and that's one of the reasons why we were so concerned about visibility. Assuming that wayfinding depends largely on external cues, we were wondering, can people even see these lines when they're underneath the bumpers, when there's beds in the hallway, when there's monitors? And we found that, as far as we could tell, it was okay. There certainly would be times when beds and other equipment would obstruct people's view, but people would assume that the line was continuous, and they were. And so if they lost sight of the orange line, for instance, they would say, okay, I'll keep walking forward, and I assume it'll just be on the other side of this equipment. And so patients, visitors, and staff were not completely helpless, even when there were faults in the wayfinding system. They were active problem solvers and just made very intuitive guesses to accommodate the real world complexities of the emergency department, like beds or monitors or other equipment obstructing the lines.
And that's one of the things that we can rely on in user experience, these so-called gestalt cues, like this idea of continuity. If something's broken up, we can kind of assume that it might keep going. So in the absence of a ton of clutter, I appreciate that you thought about how individuals might see a continuity within these lines in the hallway. All right, a couple of nuanced questions that I want to get to for a handful of people before we wrap up. Some questions about your benchmark hospitals. Which one was the Rochester hospital that you mentioned as a good example of wayfinding strategies? Was it Rochester, New York, or Rochester, Minnesota?
Ooh, they're probably both good. I was thinking specifically of Rochester, New York.
Awesome.
Although I'm sure the Mayo Clinic in Rochester,
that's what I was
Minnesota,
thinking too.
Is also quite good at probably everything they do.
Yeah. So Marianne and Katie, Rochester, New York. Sarah has a question. How long did your study take to complete?
Oh gosh, from start to finish, about 2 years. It took a long time to go through that discovery phase and determine what do staff want, what are staff willing to use, what can we afford. There was the delay because of the Joint Commission reaccreditation visit. It took some time to get the facilities team on board. By the time the article had published, we had been working on it for about 2 years.
And we know that even publishing an article can take a while too. So thank you for coming here to chat with us about the article and making sure that all of this time and effort that you put into your intervention and then publishing the research is actually disseminated to folks on design teams who can use this in the future. I want to end on this note from Sarah Oakley. She said, it would be fantastic to have a collaborative Zoom call or focus group to discuss what's working for different facilities throughout the US. She said, I find personal investigative results and feedback from end users is invaluable. Sarah, I love that you mentioned this. I love that you're emphasizing the importance of collaboration between researchers and firms and having a longer conversation than this hour to keep up the work that Michael is doing. Michael, I'd also like to draw your attention in the chat to Patricia Palmer's note, also someone interested in continuing the conversation. And Steve Schmigdal in the chat as well with a question about the Colorado firm that provided the tape. So a couple of opportunities for you to continue on this conversation. At this point, I think this is a wonderful time to wrap up. Thank you so much for joining us, Michael. And thank you again to the Health Environments Research and Design Journal for providing free access to the articles that we discuss. Be sure to subscribe to the journal using code HERD20 for 20% off. There are also some upcoming events through the Center for Health Design. We are hosting a modular design and prefab workshop. Prefabrication and modular construction are among the biggest trends in healthcare today, and by the look of the current trajectory, they are here to stay. This one-day virtual workshop provides the latest in design thinking for prefabrication and modular design and offers state-of-the-art best practices through thought leader presentations, case studies, and panel discussions. Make sure to register for the workshop taking place on July 28th. We also have an aging workshop coming up, Design for Healthy Aging, Solutions Across the Continuum of Care. As individuals age, physical, mental, and societal challenges become more prevalent. This intensive one-day virtual workshop explores those obstacles and discusses programming and design interventions that can assist individuals and caregivers. Expert faculty will present examples that integrate architecture, design, and technology into living environments that are not only safe, but foster wellness and longevity. And finally, again, thank you very much, Michael, for sharing your research. This concludes the event. We will leave the webinar open for another 15 minutes so that you can download the CEU forms and slides from the chat box. EDAC and AIA forms are in the chat box. Thank you again for joining us and have a fantastic day.